it's not different. So I want to share with you an approach to an FBC. FBC is like, we can write books about FBC alone. So this is like the most basic approach, and I think maybe later on I will go now to the specifics. Like for instance, thrombocytopenia is like a big topic. So maybe one day, so what I'm trying to say is I'm not gonna go too deep, but I just want us to know an approach so that you become that safe in turn when you see an abnormal, you know how to approach an FBC, and you are also able to pick up abnormalities in the FBC. Okay, so approach to an FBC. Approach to FBC or CBC. In other countries they call an FBC a CBC, a complete blood count. So okay, so if now my senior medical officer or a registrar or a consultant were to give me an FBC to interpret and come up with a diagnosis and a management plan, this is what I would do. I would first look at the white cell count. So I would first look at the white cell count, and decide, are we having normal leukocytes, or are we having leukocytosis, or are we having leukopenia? Low, normal, or high? If we talk about high, how high is high? If your white cell count is high but it's less than 30, it's likely to be an infection. But if it's about 100 and more, it's likely to be malignancy. Think about malignancy, like your leukemias. And if you have a patient, let's say now this FBC is like that, what would be my next step? One of the things I would do would be peripheral smear. Peripheral smear. And this patient would need a bone marrow aspiration. Bone marrow aspiration. Okay, let's go back. This likely a white cell count of 21, 17, 18, 19, 20. It's likely to be an infection. I'm gonna leave it there. You come here, it's normal. If it's normal, there's nothing to do, it's normal. If it's low, you know, in peds, leukopenia is a sign of infection. In adults, it might not mean so much, but in peds, it's infection. I hope you get that. Don't ever say a leukopenia is normal and not treat the child or look for a cause of the infection. So that's leukopenia. So that would be my white cell count. The next step would be the HB. This is how I always do it. The HB. How is the HB? Am I having a low HB? Am I having a normal HB? Am I having a high HB? What is happening? If I'm having a low HB, that means anemia. That means anemia. But if I'm having anemia, the next thing that I want to look at is the MCV. MCV. Is my MCV low? Is my MCV high? Is my MCV normal? If my MCV is high, it means I have megaloblastic anemia or macrocytic anemia. Macrocytic anemia. If now my patient has this, what would be my next move? I won't wait for the MO. I'm not going to go and tell my senior that, okay, the results are out, the patient has got a megaloblastic anemia. I'm going to do bloods, relevant bloods for this, to test for this. I'll do B12 levels, I'll do folate levels, to mention a few. So I'll do B12 levels and folate levels, because these are the most common causes of a megaloblastic or a macrocytic anemia. Say now my patient has got anemia but a low MCV. That's a microcytic anemia. Micro, M-I, micro. That's a microcytic anemia. That's a microcytic anemia. What are the causes of a microcytic anemia? Iron deficiency is the number one cause. So that's your iron deficiency is your number one cause. And how do you diagnose iron deficiency anemia? How do you confirm that it is? Because not all microcytic anemia, the cause is iron deficiency. So now how do you confirm that this is an iron deficiency anemia? You do iron studies. So you do iron studies, and then when the iron studies are out, they will confirm it for you. Or if they don't confirm it for you, then it means you must go on, come back and look for other differential diagnosis. One of the causes of small cells are things like sickle cell sideroblastic anemia. Any funny looking cell, majority of them are small cells. So these would be your differentials of a microcytic anemia. So I'm gonna have to remove this and put it maybe somewhere here. That's a normal. So you have a low HB, that's anemia, with a normal MCV, that's a normocytic anemia. One of the causes of a normocytic anemia is just hemorrhage, not chronic bleeding blood. Like if a patient is stabbed now, gunshot or whatever, or they fall and then they bleed and then they get anemia, the type of anemia that they will get is a normocytic anemia, hemorrhagic anemia. That's the type of anemia that they will get. But if you've got a patient that has been bleeding chronically for months, yes, they are bleeding, but their type of anemia is likely to be a normocytic anemia or a microcytic anemia. Okay, so when you look at this, so this is a normocytic anemia. It's normocytic anemia. Anemia of chronic disease is also it also has got small cells like microcytic anemia. So that's the anemia story. I'm not sure if I'm leaving, like this is like a basic thing, like a basic thing. I'm not gonna go deep on anything here. It's gonna be basic. Now I've looked at on my FBC, I've looked at white cell, I've looked at my HB. What's the next thing that I will look at? I will look at my platelets. The next thing would be platelets. Are my platelets low? Are my platelets high? Are my platelets low? Are my platelets normal? What's happening there? We all know, what is this now? This is high and then this is low. High platelets, thrombocytosis. Low platelets, thrombopenia. Then this is normal platelets. Thrombocytopenia, it's like I said, it's a very big topic. It's a very big topic. It needs you to further investigate this patient and put them where they are supposed to be. But one of the most common things, without thinking too much about it, one of the most common causes of a thrombocytopenia is HELLP syndrome, which is an obstetric problem, and also DIC, which is a medical problem. Also hypersplenism. Patient has got a big spleen, and then that spleen is just chowing all the platelets. So the easy way of looking at platelets is, am I having a production problem? Am I having a peripheral problem? Like, am I having an overuse problem, or maybe a destruction problem? So if you have a production problem with platelets, one of the hints that you can get is that the other cell lineage will also be abnormal as well. What do I mean by that? Okay, let's say okay, there are these two terms, pancytopenia and bicytopenia. So this is pancytopenia and bicytopenia. Pancytopenia means that you have low white cell, you have low platelets, and you have got a low HB. That's a pancytopenia. And this, most of the times, it points towards bone marrow problems. So the problem is there at the factory where all these are produced. So it means your investigations are going to be your bone marrow investigations. Like, you will need to do a bone marrow aspiration. The causes might be drugs, bone marrow failure, drugs that are causing the bone marrow to fail, or you might have a primary tumor, or you might have a secondary tumor that is just infiltrated in the bone marrow. Yeah, there are so many causes. Heavy metal poisoning, like mercury, all those things. So that's that. A bicytopenia, you have any combination of the two. Like, it can either be this and this, or this and this, or this and this, or this and that. That's a bicytopenia. I can promise you one thing. As an intern, when you can do this, your senior will be happy. Yes, this is just a basic. There's like more like a red distribution, a width, and all those things, which at this point none of us are required to know, but this we should know. I don't think I'm missing anything. Maybe one day we'll specifically talk about thrombocytopenia, because I think it's worth talking about. Because sometimes you'll get just an isolated thrombocytopenia, everything else is normal. Then it means then you should have an approach. How do you investigate a patient with a thrombocytopenia? Yeah. So what am I missing? I think that's it. Once again, we are learning together. I'm also learning. I'm just an intern that is passionate about teaching. So if there's anything that you want to correct me with, if there's any suggestion, if there's any whatever, a comment, just post it and let everyone see it. And goodbye, and goodbye.